Thank you very much. Thanks, Yasmina. Thanks for the kind, gracious introduction. And hi, everyone. I'd like to correct just one thing. We call it OCAD University. It used to be Ontario College of Art and Design, and it's now a university because we have graduate programs such as the MDes in Strategic Foresight and Innovation. So this book is not being used in graduate education yet, but there are plenty of parts that I think could be. So if you're in innovation education or in healthcare education, I invite you to take a deeper look as you get into it. So I appreciate your interest and your listening for the hour. I will try to speak, and very quickly, because there's a lot to cover, for 45 to 50 minutes, and I know we had some introductions, so we'll leave time for questions. I understand that if there's interesting questions, if people want to hang out a little bit after, I'm willing to, so just for that. But there's, having done this kind of talk before, I know there's a lot to cover to share what's out of the book. So this is about service design in healthcare as if we really cared. And I'm going to say a lot about the meaning of care and how that's integrated into clinical practice and different care practices. So this is important to me because after researching and writing Design for Care for nearly 4 years, I'm finding that the service design approaches and technology design in healthcare have changed dramatically. I mean, I rewrote the book a few times. That's why it took so long. But in the book, eventually I blended the canon with the state-of-the-art and then original approaches that I've learned and I practice and teach. And so I focused on long-standing human-centered design concepts and research methods that I think have stood the test of time. And then there's a lot that's new as well. So between those, you'll see in the book, and some of that, I think most of what I'll be talking about today is fairly new, but it's based on a lot of foundation work that has been very well tested out. So when you get the book, the technology examples will already be outdated. I mean, even if they're a year old, they're going to start to age quickly, and that always happens in books. But I think that the design approaches are fresh and have at least 5 or 10 years left in them, and some of them more than others. So you see, let me cover a little bit about how the book is structured and just the why of it. So I'm motivated personally by the possibility that designers can become care professionals and true partners in the full frontline enterprise of care practice, of health promotion, and creating healthy communities. That's a big order. The book doesn't cover all of that, but I think there are methods that apply across all of that. I tend to focus more on service design for care practice. But I want to see the healthcare professions embrace and partner with design professionals. And I know there are a lot of different disciplines and types of professionals on the call and that are out there and in the communities that I've engaged with. But there are very different languages that we don't yet communicate well across and that we don't share and consistently. And so, one of my goals is to create a good relationship with the healthcare professions so that they understand how to adopt and employ the different design disciplines in the best ways that they can as well as that we can. So there are 9 chapters that are organized in across 3 sectors that you see, and they're really they're separated by leadership, practice, and design focuses. So on the consumer, the clinical, and the institutional sides. And so the technology and information design in this book are really subsumed to the human needs and to the work practices approach. So if you're familiar with socio-technical systems, it's a strong systemic and socio-technical approach. But services design is both human-centered and it's system-centered, and it needs to be. So it's going to look complex. The book is going to, and even hopefully I've simplified the presentation, but I think as people work through the book, they'll find it's readable. So there are some key principles here that focusing on people, not a patient-centered approach, but that people have a wide range of experiences and their life worlds start at places before they become patients. All of us are patients at different times during our lives, and the patient experience is a temporary experience within within the life, within one's life cycle. And so if we look at the longest continuity of service that can be provided, we're really looking at people's experience throughout the different changes that occur as they have health concerns and as they seek better health. So I call this health seeking in the book, and it's also meant to take an individual system approach as well as the care system approach in the book, and to use that as a way to connect across disciplines. Not that it would be the only language that does that, but it is a way, and I've tried to connect to a number of different disciplines so that they can make sense of working with designers and using service design practices in their own collaborations. So today's agenda said a little bit about the book. I have some observations to start with. We'll discuss service design in healthcare broadly, and then dig into those three contexts of socio-technical contexts. They'll include some cases and a little time for discussion. So with that, I think I always like to start by bringing us back to the notion that healthcare is complex. We need to recognize it's complex, and we aren't trying to simplify it beyond the natural complexity that is always going to be part of this environment. That is, we aren't designing complex services, but we're dealing with a complex environment. Wicked problems are interconnected, deeply co-involved and entangled issues such as organization, education, changes in practice, changes in technology, the effects of different practices on each other, and the changes that occur within organizations from policy, from changes in the population. And we can identify a lot of these more complex problems. I think it's important for clinicians and designers to recognize this, because this is the sweet spot for design and innovation. Is in the more complex problems that aren't readily resolvable through the methods that healthcare uses today. And so wicked problems are complex, they're interconnected, and what I think is important to recognize is there's no organizational owner, and so the more complex problems may be ignored as they appear in their totality. These are problems that we cannot easily measure our inputs, our impact and the results, and as the problems and even their definitions may change as we work with different stakeholders in an organization or we proceed with design. So within the types of collaborations with clients, with multi-vendor teams, within clinical organizations, we're always going to be in situations where we've got multiple people with different points of view of what the problem is, different boundaries, and it's going to be like the six blind men and the elephant in the John Sachs poem, where everybody's believing the elephant that they're holding is the way to see the problem. And so the healthcare hates wicked problems, generally, because they go against not so much the mission, but the core, the values that run the large clinics. That is running efficiency, mitigating and managing risk, and managing costs. And managing costs and risks, of course, means dealing with having to manage disease conditions, patient flow, and the management of all the different units in ways that mitigate the overall complexity. And so healthcare organizations often have very strong process improvement groups. They manage processes with Six Sigma and quality improvement, looking to drive out variation within the processes, fixing what can be measured, managing to what can be measured, and setting those metrics often as goals, at least with administration. Clinician goals, and objectives often deal with meeting quality, quality standard of, the standard for quality of care, which is measurable, and standards for throughput and workload. And this doesn't leave a lot of room for innovation. So when dealing with wicked problems, the healthcare mindset or the industry mindset is to isolate problems, provide owners, and to bring multidisciplinary teams to the more complex problems as needed. But yet, when the mindset is still, historically oriented towards fixing the problems that we can understand using scientific method, a positivist approach based on best evidence, hard evidence as it's called, that starts to actually drive out innovation, but because it is driving out variations, actually taking out some of the sources of innovation. So there's a dislike of ambiguity, of course, and I think that ambiguity in practice and in complex situations is where we meet the opportunity for significant improvements to the way things are done. So I will. So if we look at what not all designers, but the design disciplines and the way that we look at it, I think from a service design perspective, is that service design and designers that aren't already assigned to functions within large clinics or employers are often not understood that well in healthcare roles, and when employed are often fragmented by role that is often positioned in a very specialized location and not given a lot of leeway to work across units or across multidisciplinary teams, except maybe from time to time. The different disciplines of design are not distinguished well in healthcare. That is, they may have graphic designers working in communications, IT and information designers working in IT or the hospital website. There may be and an organization is going to be lucky if they have any service designers or multidisciplinary designers that can work at the organizational or even at the community levels, because I think that's where a lot of the new value is going to be. So it is unclear where our organizational teams, where the potential for the creative contribution design will be. It's unclear how designers work with research teams, or how we would publish research, and how that would look, and how design-led research could improve healthcare outcomes and could add to the literature. And because of the variation in designers and the difficulty in placement, one of the things I've noticed and that I hope that that our discussions can improve is designers often get placed in kind of dead-end situations, and they'll end up in IT when they need to be working across services. They're using IT or working with EMRs or changing user interfaces, integrating user interfaces for effective information work when they ought to also be working in improvement of clinical processes, working at a more macro level. Not just on public websites or within IT or within process improvement. And we're also not rewarded for creative risks, and so that leads to less value that could actually be brought to the entire organization. So if we look at where this is a map of the Cleveland Clinic and a kind of a layout view of their new services center with the main campus and just kind of an overview of the complexity of all the different units, wards, and buildings on their very large, sprawling campus in Cleveland. And so, when looking at that as a metaphor, I'd say, so, where would the designers be located in a large physical plant, physically located? How are they given access to the institution, to the organization? So healthcare today, acute care practices, Cleveland Clinic actually is different, and some of them are very different, but on the whole, large tertiary care, acute care centers are oriented towards the throughput, to the assembly line approach to move short-term incomings through the system, placing patients in the right bed, the right room, minimizing risk, and maximizing throughput for busy clinicians to deliver care services. So where do you place designers to learn and contribute, and can they maximize the value of the different design disciplines that they have? So one of the places I would then return to are the types of wicked problems that commonly occur and are common across the different healthcare communities. So if we look at where wicked is in healthcare, things like integrating the clinical services and the therapies and communications with patients to community services. So there's connection between the hospital and the large clinics and the smaller distributed clinics and community services, and communications in the community. Patient information that's consistent across their care journeys and between primary care and their specialists. The coordination of clinical teams is a constant concern. There's a lot of literature on this. I think it's a huge area that service design, information design can certainly help develop, but hasn't really, I think, even begun to really address this. If you look at the leading studies, there are some information designers starting to show up in this, but it's a constant issue, and it's one that's going to show up in almost all hospitals. Redesigning the electronic health record systems, the vendor systems as they come out of the box are essentially like SAP or ERP systems. They're generic, and they do have significant workflow usability issues. All of them do, and the smaller, the smaller general practice EHRs that are better designed don't scale up to the very large practices. There are some state-of-the-art, certainly with Kaiser Permanente. Some of the very larger hospitals in the U.S. have done some great specialized work. But I can't share that with you. In fact, you'd have to sign NDAs for many of them to share it with you. So it's not, a lot of that isn't even in the book. I tried, and I tell you, that's one of the other issues we have, is the open access to learning and exchange of issues like this. So those are a few examples. Also, new business models and how that's going to change the systems of care, how we distribute care as hospitals disaggregate, how patients or people seeking to treat or to deal with their own conditions, their own information, can self-serve to the extent possible in more local clinics and take some of the burden off the throughput in the large acute care settings. So before we get into actually like the how and why, how of this, I want to touch one more time on the why. I said in the introduction about mentioned some of my motivations, but I think it'd be good to clarify here what I mean by care. That this quote by Milton Mayeroff from the 1970s book on caring expresses what I believe to be just the best statement around what we could take as a normative stance with respect to the meaning of care and what I mean by designing for care is to help people within our lives and our communities grow, to help the people that are in our lines of service that we're working for, and in this case, patients, clinicians, and the whole systems of care, working together to improve the real meaning of care as much as possible. So there is I like that Mayeroff says that the way to measure that care has occurred is that the recipients of care have grown from the experience, and this is very different from the kind of core value or the received notion, I think, of care as value that's delivered, or that it's a package or of medical procedures, or it's a service that's measured, delivered, and charged for. Physicians and nurses go into their training and dedicate themselves to their fields because of an inherent desire and motivation to provide care. I haven't met a young medical student or resident yet who isn't motivated this way. And yet as they go through their training, some of them realize what it's going to cost, and they have to have kind of a lot of the empathy beaten out of them in order to actually conduct the invasive procedures that you can't believe that they do. And some of you are probably physicians. You may have your stories about that, but in my observations, and a lot of them have been pretty direct, maybe I'm over-dramatizing, but they are There is some concern for how empathy might get lost in the translation of through medical education. I think a lot of that is, while there's a strong caring there and a need to care, and this happens with designers as well, we need to be able to work day to day with these complex situations and to actually treat people. And so that leads to a kind of separation, not a making of the other, but that there are many different meanings of care, and to provide the best procedure may sometimes mean to focus on the delivery of that procedure, but not to treat care as if it were just delivered as a package. So there are ways that I think service design can start to encompass some of the essential meanings and core values of care and caring in this way. So I think that we can ground our own practices and experience more into some of the notions of human-to-human care, the circles of care, and what a care practice could look like. And so there are different levels to this that I'll talk about, and then look at a services approach for that. But I guess the question I would leave at this point in the talk is, how does design for care offer care as a service then? So at this point, if there are any questions, I see that I'm going to look at the tab to see if I've got any questions at this point. And if anyone wanted to break in with one, this might be a good spot to just take one. So there'll be another point during the talk, so I'll continue from here. So so care expands well beyond the clinical. That is, people do experience care in their own circles, their own families, in their communities. That's where they primarily experience it, of course. And in modern societies, and I'd say in the urban experience, people living in large cities like I do here in Toronto, some of the access to care can be precarious. As families are fragmented, people are living in large buildings, or sometimes don't have a sense of community. And so one of our design goals should be to facilitate the experience of care in whatever situation we're designing for. So the picture that I'm showing here, there's a lot here, but I'll boil it down to its essence. This is a view of our persona. It's called Elena, whose story continues from every chapter in the book. And she has a series of situations that are diagnosed from primary care through ambulatory specialty care and then aftercare, as you see in the primary. You're kind of in the five main boxes. But their starting point is actually as a caregiver with her father. There's a circle of care within the family, friends. This understanding that that she's taking care of her father until an incident, a particular incident brings her into a series of diagnoses and then into specialist procedures for a cardiovascular concern. Supraventricular tachycardia is the problem that takes us through the book. It can be kind of complex, but the treatment for it is done thousands of times a day. But the story of Elena is treated as a process of health seeking, and this is a way to map the service design experience to the broader view of what occurs in individuals seeking of either maintaining care, or in some cases seeking health as a ongoing homeostatic process to essentially return us to what we believe normal is. And for some people, if you're an athlete, normal is really a very optimal state. And athletes like to measure their state, have a quantified self-movement. There are a lot of people who seek to actually improve their state well beyond what we might, physicians would say are normal. But the normal, normal homeostatic state of just maintaining a good, well-managed, biological person within a good environment and a healthy community is a fairly adaptive system. And when we encounter either a disease conditions or acute conditions that change that situation, we seek to restore to normal quickly, and there are a series of concerns that occur. And so I've identified those as part of the journey in these types of maps. And rather than walking through the whole thing, you can you can kind of see what the timeline is here. That after a couple of years of caregiving, Elena has an incident. She goes to primary care. This is a 2-month period of kind of a series of visits, diagnosis, and then there's another breakdown in which her diagnosis is then confirmed that not only did she have early onset diabetes and hypothyroid condition, it's diagnosed that she has a cardiovascular condition at the core of this that's exacerbating things. And so it goes from 2 weeks to then scheduling an ablation, an invasive treatment, which takes her into a completely different context. And her circle of care gets a little smaller with each one of these treatments, because when you get to the specialist treatment, you need more specialized care. She's going to be at home, maybe visited by people, but the larger circle of care that she's actually part of when kind of in the normal state doesn't actually follow every stage of the process. It could, but it doesn't usually. And then there's this living with process, the aftercare, where I think there's a lot of opportunity for connection to communities in a well-designed context. Now, I want to take it from this kind of context of health seeking now to look at a context of design again. And I like to look at or consider this view of 4 levels of design that we call geographies of design. I worked with Humanific on this model a few years ago. They're referenced in the book. It's essentially 1.0 through 4.0, but not as a series of going from 1.0 to 4.0 like Web 2.0 or Health 2.0. But these are completely different kind of domains of skill, of design practice, of the skills that are necessary for dealing with the complexity within each one of these frames. So we could call design 1.0 a traditional design context of graphic communications, not that it doesn't deal with complexity, but a single designer with good skills can deal with the types of issues that we might call a design 1.0 context. Number of stakeholders are few, the need for collaboration, maybe things are reviewed, handed off, communications, even website design, once a website is well established, let's say. But design 2.0 gets to the level of product and service design, a lot of new ideation, multiple stakeholders, more complexity in dealing with the right, understanding the value that's going to be delivered. But products can be quite complex and deal with very large markets, have to be designed for use by thousands or accessed by millions of people, and that has to be done with an eye to understanding user experience, doing high quality research so the case can be made for the product or service design. Now, yes, I am talking about a service design approach, but it's beyond the defined service that we might have in a more, let's say, in a commercial company's context, where they might have, so a health insurance firm may have insurance services that are presented as a mixed IT product and services context. That would still be normally a design 2.0 because you aren't changing the organization to do it. Design 3.0 is an organizational transformation context. And we look at large clinics, very progressive hospitals that are constantly, they don't constantly change their business models, but they're constantly reflecting on how to stay ahead in their field, the right acquisitions of technology, the changes to practice, staying ahead in research, maintaining the highest quality standards of care. That type of reflective management and organizational work supported by design is what we would call the design 3.0 context. And so the next slide will show more of that. And so so if we look at the different kind of bundles of products and services in each area, you can get an idea of that each of these geographies deals with higher and higher levels of complexity. And so when we get to design 4.0, or which can be considered generically social transformation, but in the clinical context, it would be the organization's interaction with the community, with health policy, with changing policies, and whether it's regional, national. I'm in Canada, so actually Ontario's Ministry of Health and Policy Making is actually very advanced, and they're constantly doing research at the policy level, and that deals a lot with the kinds of issues you see with the bullets here, integrating clinical community services in the U.S., the development, I think, of the Accountable Care Organization, the ACO, and the new distributed care models. Those should be looked at as high complexity, advanced clinical care services that reach a level of Design 4.0. What that means from a design skills point of view, if you look on the right-hand side of that particular slide, are having skills to work with the complexity of multiple stakeholders, having facilitation, design, multiple team skills, and being able to do research between the organization and the community as well. And so there's a kind of progression of these. I guess I've taken the wicked problems and arranged them in ways that define different solutions for those sets now that can be, and then almost any of those could be seen in the service design approach, even like wayfinding in the health design 1.0. And so service design, I think we all can look at that in some of the ways that it's been published in the last few years as a patient-centered approach to experience design, improving the patient experience in clinics and insurance and health systems, a human-centered design approach that traverses the different touch points of care, therapies, and clinical encounters, the orientation of designing for health, the new modes of design over this last phase of design thinking has been guiding us towards design for intent, or design for care, or design for health, I think is one of the broadest frames that we could employ. And that's fine. And service systems, or the integration of technologies and work systems and organizational practices as an integrated service system, that could be a mix of design 3.0 and 2.0 if you look at that in the book, and there are chapters on that. But I wanted to bring up again, this is where I think in service design in healthcare we need to go back to some of the foundations, such as socio-technical systems, which has a deep and rich literature that informs the research base for understanding the work practices, the employment of technology, the conflicts between new technology and very well established work practices in organizations. And so from a socio-technical perspective, we might take a layered view. I mean, a one view of socio-technical systems is one from that you'll find in the human factors work of and cognitive engineering models of Jens Rasmussen, Kim Vicente, in his books like The Human Factor, and their research over the last 30 years. And we can define this kind of onion view of how a human, and this could actually be somebody who's working in a care environment as well as a patient, but I think it's best to look at the patient as a person who, in a sense, it's person-centered across that whole journey. But within the clinical care environment, we're designing services that can work across those different levels and provide feedback between those different levels. And so those three contexts I'm going to touch on quickly with a little case for each one here, so just a few minutes on each one. And so with the person in the center of that onion view, so I'm thinking of people not even as users, because that tends to push us toward a user-oriented, user-centered view of design, and toward designing for tasks or designing for a particular touch point that has been blown out to, say, a therapy or the time in a unit, or things like wait time experience, patient experience, and reducing wait times in the clinic. I mean, I think we need to move beyond that, really look at the person's experience before, during, and after as much as possible in the clinical environment, or within the other many other areas of healthcare as well. The reason I wrote the book was all of us who work in healthcare only work in one slice in one sector, and we only see this user, this person, this patient in that view. We don't ever really do research on all the other touch points and aspects of the life world of the people that we're studying. We study them for the purposes of our projects and our clients very much, but not for that whole experience. And I think we need to look, if we consider how people are experiencing their own lives as a process of health seeking and maintaining health, we can start to look at a richer view of their journey and provide services across that spectrum. So I'm going to say hospitals here for the second context, but I mean, just because they're the largest employer, they're some of the largest employers in the world, not just in the U.S., I mean everywhere, and the systems that they're part of, you would say. But we could also expand that to the health systems. But to actually put it into a context, a lot of the work that we need to do is improving the changes in hospitals as they start to, their trends are changing them radically in the next 5 years. And so this is actually, I'm looking, it's not just business processes or clinical processes. Hospitals have a very deep cultural rootedness, and we need to look at the cultural design of these institutions and what they mean in our societies. It's a design of meaning. And then healthcare itself at the policy and at the integrated level within our societies as, in a sense, the integration of everything. So when we have mandates for the inclusion of technology for electronic health records, such as the HITECH Act, one of President Obama's first policy initiatives in first year in office was to provide the HITECH Act with billions of dollars of incentives to move to electronic medical records. There's a rush of hospitals to take advantage of that, and now they're stuck with these big vendor systems that they now have to integrate. And it's a cart before the horse. Yes, it happened quickly, but now what? So let me go back to context one and say a little bit about design there. So here, if we're all health seekers, think of yourself, we do not self-identify as patients. And so designing for that experience of the patient is fine, it needs to be done, but it should be part of the overall view. And if we need to somehow get access to that patient when they're in the other parts of their lives to understand how they're finding our messages, how they're discovering what fears are concerned, how to really, what fears they have as they're contemplating the different treatments and therapies and changes to their lives that medical care will do for them. So we need to be designing for people in that sense. And so we're, so this is, in a sense, I'm interested in designing for care experiences, but that experience can go well beyond the delivery of what we think of as institutional care. So the kind of promise of that experience, if you will, going back to Elena's health-seeking journey, I'll bring the same slide back, but here just point out two areas where we really can look at careful design to the to the person's understanding of their future diagnosis and future care treatment, their self-care, the communications between different clinicians and specialists. And the 2 points are right at primary care. They're getting their initial diagnosis, and right after that is they're starting to pay attention to the to either the changes in their experience after medication and before their next visit and so on. It's a critical time for self-reflection. It's a time we don't usually have access to. I think it's a very highly leveraged point for continuity of service. And then following the final therapy, in this case, when there is an invasive therapy or a surgery, there is a lot of aftercare, a lot of observation. This is also a point where people really, they're going to receive the value of the treatment. So if we think about the value of healthcare, it's very different than other value received in other types of services. In healthcare, the value received is not the treatment. It's a transaction, there's a process, but the value received, I think, is is, I mean, there's more than just the co-creation around that treatment. It's when the person starts to feel normal again, or when they've reached a homeostasis as in the next level of their health state following care. They've reached that level, and that's the recognition of that is actually, I think, where we need to look at where value is realized. It's a different view of service, and I don't know how we reach that yet. And so these get to problems around continuity, and the problems that people within this life cycle experience are that they're often left on their own to figure out what their next. They have orders, but they're not sure that everything is being dealt with, and they're not sure how to deal with. They do a lot of patients do a lot of pre and post visit self-diagnosis and self-education, a lot of research on the web, and aren't always sure what to make of that, and it helps inform their next steps, but not a lot of guidance. And people who have more serious health issues often have to work around the system that they're led through to get the best care. They may need not only second opinions, but to work it through their care, their own circles of care, to really get a sense of whether they're on the right track and find better ways to communicate. And it's not easy. You can't just email your doctor usually. And there are a lot of differences in the ways we communicate with other professionals and in the clinical systems. Also, the episodic care, scheduled visits, can be very disjointed. And the connections for information, education, and supplementary treatment can often be missed. Also, people are very bad about adhering to the treatment schedules and medications. And there are a lot of point solutions now for reminders, medication reminders, but even doctors will often not know all of the medications that a person is on, or the other things that they're supplementing with, or how those medications interact. So the continuity is a very big design issue, I think, and one that's complex enough that designers should get involved, things like the clarity and reliability of the data. So in continuity of care, one of the cases that I go through in the book, and I'll just touch on here with a couple of examples, is a project done on the continuity of care document, or the document that travels between physicians for a patient who's receiving a series of treatments around a complex situation, whether it's cancer or cardiovascular, and they're going between specialists or from primary through specialists. And so IDEO organized with the California Healthcare Foundation, and I see I mixed the acronym. I'm going to have to fix that. I'm just seeing that real. So it's the California Healthcare Foundation. So that will be fixed in the slide share presentation. So sorry about that. This is one of IDEO's constructions of one of the maps that was created in the workshop that they conducted with California Healthcare Foundation and the several major EMR vendors that were organized in the same workshops to identify different ways that the continuity of care document could be understood and carried through the different touch points of the care journey that a patient in common was going to be experienced. And I like this one because it showed a kind of network map view that shows the different encounters that are being planned and the handoff points, and both the patient's perspective on the right, the different patient needs that are checked off that this meets, but the physician needs, which are on the bottom, and the physician's view of, I guess also the patient's view of that network of interactions that the different physicians need to be aware of, and that the patient is going to be visiting. And there were a number of different mock-ups that resulted from this. This one, this isn't the one in the book, but what this shows, I think, from a very simplified point of view, that a patient might understand their continuity of care in an integrated way by seeing a strongly visual presentation as the IDEO and CHCF view shows, that the context of the patient, their care team, and their visits can all be illustrated together to give a holistic representation of what is happening, where they're located, and what information is critical to them. And so I see I probably have to my. I was hoping to talk for 50 minutes. I know we had about 5 to start with, so I'm going to go through 2 and 3 pretty quickly here. So the clinical service model or level as a socio-technical model is you could say service design today may be looking at primarily things like the care pathways that are designed within a clinical context for helping clinics, institutions map out how treatments are delivered for different known disease conditions to facilitate efficient throughput, to be able to identify the right roles and the teams that are supporting and the different points on a care pathway. Care plans are developed by interprofessional teams, and I think they'll be improved by designers to identify the right therapies and follow up and treatments both within the clinic and aftercare for those conditions. So in a way, care plans can be mapped to points in the care pathways or can encompass them. But there are also what we could call care bundles, which are co-occurring, especially for co-occurring issues, for iterative problems. And so care bundles are ways of us organizing for sequential or iterative or complex care, these different aspects of organizing care. So sequential care is more typical. Typically, the way that acute care clinics are organized to move patients through, emergency to the unit that they need following their emergency, or if they're an inpatient, into a particular unit, and then through aftercare and step down aftercare, and these sequential models. Iterative models of care are what designers need to be looking at in service design, or this is where more creative problem-solving approaches to treatment are taken into account. And so we can also map those kind of clinical care contexts to the same design 1.0 to 4.0 as I've shown here under clinical design. So clinical design 1.0 might be fostering self-care, helping patients be more aware of what they can do in a preventative context. There's a lot of communications involved, but it may not be that complex, not a lot of stakeholders. Design 2.0 is more the patient encounter, or dealing with the direct exams situation, better patient experience, diagnosis and treatment, care pathways. 3.0 for actually working with the organization, the business model, healthcare teams, care planning, and 4.0 for community health views. And so this would be designing more for the value demand and less for dealing with the interventions of disease. Again, the patient context is temporary, and we need to be dealing with prevention, adherence, continuity issues. So across the life cycle of health seeking, I believe. And so in this view is more in the care context, where each of those incidents has a different feedback cycle. So from primary care to specialized care to an inpatient procedure, there are different follow-ups after each one of those points and interventions that need to be dealt with. So when we look at the different points of care design within the clinics, we have to also look at the everyday life of the clinicians that are providing the services that we're trying to improve. The day in the work life of a physician is as intensive as I've drawn here. One of the diagrams I like to use shows the complete day in the life, from the information resources used from the electronic health record to preparing for the cases and mapping out the day's schedule, and a very high level of intensity of both information and work throughout the day, with a couple of breaks. And if you're a surgeon, like in this view, you're in the OR most of the day, and so the patient or you are visiting the OR just for that brief period of time. So layered onto that clinical and technical work are multiple IT resources and interfaces and cognitive tasks that need to be dealt with and by information. And so this is a map that you can see in the book or review online. There's a Flickr. All of the images in the book are available on Flickr and can be reviewed and downloaded and used even in your own presentations with attribution. And this is one I like to point to because it shows kind of the clinician's journey. Maybe even in a 10-minute period, they may interact with 5 to 7 different information interfaces and to make decisions for one or multiple cases based on the flow from electronic health record to identifying the patient and the schedule to looking up something about their case to maybe digging into a current if they're a resident in particular, they might need to refresh the procedure for that day, need to reflect on, and they may need to see how it's going to be booked or who else, how it's going to be, where that's going to show up on their schedule, for example. So they may actually touch multiple systems, each of which have a different interface and that provide a fragmented information experience. And then they're expected to perform immaculately every time, perfectly, over and over again with this. So this is an area that isn't just user experience design or information design. I mean, every one of those systems has a different vendor. We need to have ways of integrating those experiences in the institution. And so finally, number 3, the level of the institutional design. You could say that we're dealing with big box healthcare, and the disruption of large clinics is happening by cost more than innovation or technological innovation. A lot of the innovation that's occurring now is at the system and the clinical level. And so we could say this is at the technology disruption is more supply side, that as we develop information technology, it's adopted, it actually gets integrated and doesn't have it maybe disrupts a market of other competitors, but doesn't really disrupt practices. It gets adapted to and integrated. But we need to be looking at the demand side, the fact that there's a primary care crisis in the U.S. and actually the developed world, and that, for example, in the U.S. people only receive, or the population is receiving about half of the recommended medical services that they need. We have incidence of 25 to 28% of obesity is showing up in the clinics and growing. We have a huge incidence of adult onset diabetes, type 2 diabetes, and only 43% of them are being treated, many of them with hypertension at risk of stroke. And so we need to deal with the complexities with the aging population. So again, in the book, you can read this, but an example of how that's being dealt with in Ontario, so the Centre for Innovation in Complex Care is changing the really complicated atrial fibrillation care system today, which looks like this, a lot of interconnections between community care services, the hospital, acute and other institutions, and the patient really doesn't know where to go. This is becoming worse because as the baby boomer population ages, there are more and more comorbidities that are showing up in the population, and so it's a complex care, not just atrial fibrillation, which can be very dangerous and lead to stroke. So they've recommended, and this is at the policy level, a system that puts the patient in the center and provides clear pathways for the integration of the regional and local clinical services. You could say this is a macro service design approach even. And they've developed different tools and resources for presenting personas to understand the different personas and workflows for the different types of patients who we would expect in that system, and the different tools such as this prototype of a handout which has now been produced that people can kind of self-diagnose. And so in conclusion with those examples, I'd just like to close with saying that one of the things that we're finding is kind of a barrier to innovation is that we believe everyone wants the same thing, as Rosenfeld Media says, that everybody in society wants to help people get and stay healthy. But that the bottom line is that innovation is always going to be changing somebody's practice or to change the way things are done, where it may be at odds with process improvement. So these are some ways to look at how to start integrating care designed for care into the care practices. So here are some ways to follow up with me, and if you have any questions, I'd be happy to take a couple quickly, and I'm happy to stick around if anyone can. So thank you.
Thank you so much, Dr. Jones, for an outstanding and fascinating presentation. We do have actually several questions that have come in. Are you able to see them?
Well, I'm clicking on the red tab. Do I need to actually refresh the browser?
No,
Is that the deal?
the Q&A tab. If you click on that,
it is. I'm clicking on it. It's not giving it to me yet, so maybe
okay.
I'll have to read a couple.
Sure, absolutely. We had a question come in earlier from Marcel asking, hello, Dr. Jones. What are your ideas on designing for telehealth systems?
Well, I actually don't cover that a lot in the book because I think it is also really well covered. It should be an integrating service for one thing. Patients do, I think, care where their treatment is coming from and who they're working with. And one of the great things about telehealth, it's being used a lot in Ontario. One of the great things about it in Ontario is being able to provide care, procedures and diagnoses and interaction with patients that may be a 24-hour drive away or a very long flight away. I mean, the rural territories in Canada are huge, so telehealth is certainly a is a major service being provided up here. I think what may be missing, especially in the rural healthcare context with telehealth, and something we can learn from because it has to be done in these extreme rural conditions, is that there needs to be real attention to the local context that the patient is going to be into, to lessen their fear and concern, and to be able to provide aftercare to supplement the loss of immediate contact with the primary physician who may be diagnosing them, and they have to trust them. A lot of people in rural situations, in rural geographies, maybe, I don't want to say less sophisticated, but they interact with, they use health services much less frequently because the clinics are not nearby, and they may be in underserved populations. They may have traditional means of accessing care. And so one of the case studies in the book actually deals with one of my grad students' projects, or touches on a project with providing rural health care in a First Nations context. So in Canada you have a lot of Aboriginal communities and First Nations that are in these rural contexts, and they actually have their own traditional modes of health. And I think telehealth needs to be sensitive to the communities that they're interacting with, that they're not just be in a mode of efficiency.
Thank you very much. Another question here. This one's from Anita. She says, Dr. Jones, which approach do you think would be best for finding friction in healthcare services? Patient interviews, clinician interviews, or caregiving interviews, or something else?
Now, that's a good question, because finding friction is a good way to, I think that's a good way to characterize the discovery of places for intervention and for a design approach to friction that may be persistent. So what we want to look at are not the idiosyncratic places that may occur with particular patients, but I think we would want to start with a combination of observations in the places where friction is known to show up within a particular community setting. Different communities are different. Hospitals actually have different purposes because they adapt to their communities. Some hospitals see a lot of mental health diagnosed patients that show up to emergency because they hurt themselves, and so they treat the acute issue and then discover that they can't take care of themselves that well. So there is friction there between the patient and their inability perhaps to deal with their own life circumstances in a good way. And so there's a need maybe for more community care that's closer to that individual's own home or region, local context. And so that's one point of friction. Friction within care delivery or in the type of a particular unit I think is best understood by observation and clinician interviews. At first, anyway. I mean, so if you're dealing with pediatrics, for example, you have parents and the children as the direct patient, and the parents as those that are concerned, need to all understand the situation. There's a lot of communication needs to occur. I actually think nurses are a great place to start for really understanding this area of kind of the emergent discovery of possible interventions for improving care, either directly or for testing the care plans, or for even from a process improvement point of view. Sometimes, I'm trying to maybe point to an ideal situation that we aren't in yet as designers, but I think if you're working in the field, we need to recognize we work from where we're already located. And so if we're in a kind of process improvement and a care delivery modality, we work from that, and we look for things like the points of friction from there. I think you can start to make a good case for a broader innovation if you start to identify systematic frictions or systematic breakdowns, misunderstandings, communications, or differences in role between nurses and physicians or others in a particular care plan or pathway. And if that's the case, then I think that designers are actually integrators, and we list. So I think that's a place to look.
Super. Thank you so much. Just a couple more questions coming in here, folks. We are just going over a little at the top of the hour here, so we'll try to get to as many questions as we have time for. We'll take this next question from Jonathan, who asks, Dr. Jones, how do you see the future of EHR designs? What things should we count for when designing electronic medical record systems?
It's a huge question, and it would be the subject of another book if I were allowed to write it. I mean, I know a lot of people who work in this area, and they consulted and advised with me on the book. I originally had a really good chapter on this, and now it's a backup chapter. I actually, as you see it, because the original chapter was written on a well-known institution that is doing state-of-the-art work in EMR design for across different clinical tasks, and they're redesigning the interfaces over the Epic system. Now, I can't show you Epic, and with NDAs, non-disclosure agreements, I can look at the projects, I can hear about them and work with them, but I can't publish about them and even if I'm working directly. I mean, this is a very difficult area to work in because of the commercial protections on the exchange of free information. So I think the number one, the future of EHR design needs to be open source systems like World Vista as a basic platform, but moving that 5 years forward into, I think, government supported and open source community supported modes of interoperable modern database systems that are licensed and royalty free, and that are also interoperable with today's MUMPS-based database systems that we're seeing, that we have in today's large vendor EMRs. But I think the current future is going to be the same as in terms of user experience design. We'll be designing for the most common clinical tasks in ways that can be passed down to mobile and tablet displays that will often be embedded. I mean, some of them will be mobile and some of them will be positioned so that they can be kept clean. I mean, there's a serious concern for things like infection control and passing between patients as doctors move around. The white coats don't fit, most of them don't fit tablets right now for a reason. They may get around that with new materials, but I think the distribution of information from the EMR server to the different devices is going to happen, but they're doing it very carefully. So we need to design to specific disease modalities and clinical tasks that work extremely well for for the common situations, as well as vastly improved visualization, summary reports, and integrated views for everybody else. I think there is still going to be, and I think there still should be, some paper trails, not the big paper trails, but there's a need for being able to print and mark on printouts, and I think there always will be. These are cognitive artifacts that people maintain their memory states with, and if you're always having to bring up another record or to look up a patient or a situation, it can be a little fussy for a doctor. And they have the stack of, you could put them behind tabs, but there's something about the printout, and I found this in all my research, that the residents and doctors still print anything that they're really interested in. And yeah, there are a few that are really leading edge. That doesn't mean that everyone's going to follow, that there's a need for high quality print as well. So I think the future is not going to end that. It's going to optimize print and design for clinical tasks. I think some of the socio-technical designs, if you look at articles like To Err is Human and Ross Koppel's work from University of Pennsylvania on breakdowns of the EMR systems, there are a lot of people doing socio-technical interdisciplinary research on in this area on things like the design of order sets, labs and tests, CPOE, integrated with EMRs. There's a lot of research that shows what we need to do. It's a matter of how to do it from here. So a great question, and I think if you wanted to write that next book, and or somebody had access to to the information, and we're given the freedom to publish, it would be great. And I would like to see a book on enhancements to Vista and the World Vista open source system, because I think that has huge potential for the developing world and for nations and systems that can't afford Epic and McKess and Cerner, which are many.
Super. And with that, Dr. Jones, we're going to say a very big thank you to you, sir, for spending your time with us today and for sharing your knowledge and expertise with us.
Thank you. And I will post, actually I had an updated version of this that I'd hoped to show, but we went with the last one, and I've got a couple fixes on that. So I'll put that on SlideShare, and anyone who follows Design for Care on SlideShare can download that as a PDF.
Perfect. And
thank you. Yes,
oh, it's been such a pleasure having you today and the wonderful information you've shared with us. And a lot of folks chatting in the group chat, very pleased with the webcast, and they really appreciate all your information.
Well, great. I'm available online, Design for Care, but Twitter's one way. But there are a lot of good discussion groups. I've actually been following Sam Basta's group on healthcare innovation by design, and some others, and I think some of these are pretty good venues. So I'm open to exchanging there where other people can see the sharing of the questions. So. Yeah, I look forward to meeting some of you folks later, and at conferences or at other places. Please look me up.
Super. Thank you so much, sir. And we'd like to say a very big thank you to all of our attendees today who attended our webcast, and we hope you've benefited from it. We'd also like to say a thank you to those of you that sent in your questions, because having those questions just adds so much more to our events, and we do appreciate it. We would like to let you all know that we did push out a code to you all, so if you haven't opened your group chat, do open it. There's a code in there that can save you some money today as a thank you for attending the webcast. O'Reilly has a special offer on Dr. Jones's new book. So we pushed out that code to you there. You can get Dr. Jones's new book, Design for Care, at a really great price today. You can also visit O'Reilly.com. Look on the right-hand side. You can't miss it. It's right there. Again, Dr. Jones, thank you. Folks that attended, we thank you. And this will conclude our event today. Goodbye, everybody.
Bye now.